Welcome, Dr. Well. It's all yours.
Okay, John. So do you see my slides, John?
Yes, yeah, excellent, excellent.
Abhilash, do you see my slides?
Yes, sir, I see them.
Are you surprised by the title?
Divine. The spelling is
Divine.
Yeah,
unusual spelling.
Divine.
yes.
Divine is wrong spelling, you think? Divine.
Yeah.
Well, what's the context?
Okay, now you will see. You will see the context very soon. So I am going to talk to you about odontoid process in a little bit lateral manner, not in the straightforward thinking process. And let me see if I'm able to give you this perspective. Odontoid process is a bone which is like a very sharp tooth. And this tooth, every spine surgeon is worried about. This is the sharp tooth, odontoid process. And this invaginates into the brainstem and cervicomedullary neural structures. And the entire craniovertebral junction philosophy is based on this concept that this intruder, this sharp tooth should be removed. Otherwise, it will be a big problem for the patient. So as we said that there was no need to remove this tooth, you can realign this and bring it back to the normal situation. So it is always better to have your teeth intact rather than removing your teeth. Odontoid is also called dents or tooth. So this was the concept, and the main issue is this tooth is the main troublemaker for a lot of spinal pathology. And I must also tell you that atlantoaxial instability is not only misunderstood, it is understood. And without any doubt, undertreated clinical entity in the subject of spine. So this compression of the odontoid process has been the troublemonger and troublemaker for a long period of time. And removal of this odontoid tip has been the treatment. Os odontoideum has been considered to be a very bad kind of a pathology which leads to atlantoaxial instability. So this has been considered to be a great pathological phenomenon which leads to an unstable atlantoaxial joint meriting the need for fixation. Basilar invagination in general is a phenomena where odontoid process goes inside the neural structures.
Okay, there may be a halt in this internet service as usual, so just hang in there. It usually comes back, and it's usually about this time, matter of fact.
It's remarkable how accurate that.
Yeah, the outage is, yeah. He usually predicts it.
Yeah, John.
Oh, there we go.
John, I am a little bit troubled by these frequent breaks. So what I will do is maybe, let us see, John. So basilar invagination as an entire concept is based on how to treat this invagination of the odontoid process in this group and how to treat tonsillar herniation in this group. So I was doing transoral surgery for a long time, and my number of cases were going in hundreds. And every year I was demonstrating in this part of the country and that part of the country and various places. And
Hang in there.
okay, John.
Okay, very good.
John, what my problem is, I'm working from home
Right.
and I'm not getting a good internet connection. Maybe I can give some days break and come back when I'm able to transmit my lectures from my department after this lockdown business gets over. So let me think about it. Okay. So essentially, this odontoid tip has been the issue, and odontoid process has been considered to be a very, very nasty or notorious bone. So this is another thing that we had started introducing these metal implants, and then I had removed the entire iliac crest and introduced in this area. So I was doing a lot of transoral surgery, and after transoral surgery, whether fixation is necessary or not, ultimately now we have come to a conclusion that transoral surgery is a very historical kind of a situation. Now, what about odontoid process? And my title says that it is not an ordinary bone. It is an absolutely divine structure of the body. So this is the craniovertebral junction, and odontoid process is stuck right in the middle. This craniovertebral junction, this is the atlas bone, this is the large lateral transverse processes from front. This is the center for mobility, and craniovertebral junction is the center for stability of the most stable and most mobile structure of the body. Now, there is no disc in this region. If you see the literature, and if you have seen my previous presentation, I was saying that disc is the most mobile and most stable entity of the body. It gives stability and mobility and shape to the spine. But there is no disc here. So what is the answer? Why there is no disc? And what is the function of how the function of the disc has been taken over in this most mobile junction and most stable junction? So we had introduced this concept that odontoid process is actually a replica of the disc. Odontoid process takes over the function of the disc. If you see, there is not a single muscle attached directly to the odontoid process, and anterior in this area, not a single muscle attached. Similar to not a single muscle attached to the disc. So I will like to elaborate on what I am saying. So this is the beautiful craniovertebral junction, odontoid process right in the middle of activity. There are various pulleys attached here, pulleys attached here, pulleys attached. Pulleys means muscles, muscles attached to the spinous process, to the transverse process, various muscles attached to in the vicinity, nothing attached to the odontoid tip, nothing attached in the front, everything is from behind. So to introduce this concept for the first time in the literature, I am going back into the embryogenesis and going back into the craniovertebral junction of various animals. And first animal that I'm introducing to you is a horse. The horse is a very strong muscular body. All the muscles are located lateral. Craniovertebral junction is very strong. The movements of the neck are very, very strong. In human being, the movements of the craniovertebral junction are 70 degrees, but here it is almost 120 degrees rotation of the neck. So how is the craniovertebral junction different in a horse than in a human being? So this is the dissection, not dissection, these are the bones that of the craniovertebral junction of a horse. Now you see the beauty of this. Beauty, you just enjoy the beauty which I'm showing you. This is the C2 spinous process, which is quite huge, as you can see. This is the C1 arch. You see the beauty of this arch. This is the C1. You see the quite a deep facet for the condyle of the occipital bone, very deep condyle. And in this C1, the facet of C1 is almost completely complete circumferential. You see the facet of C1? And the transverse process of C1 is quite huge to take care of muscle attachment, quite strong muscle attachment. This is the C2. You see the quite a large spinous process of the C2. You see the facet of C1, the articular, this is C2, this is the odontoid process. You just see the odontoid process in its divinity. This is the C2, this is C2, this is C2. This is the articular surface for C1. This C1 articular surface is quite flat. This occipital articular surface is quite deep. So C1 and C2 articular surfaces are relatively small and quite flat. This is the odontoid process. You see the beauty of the odontoid process like this. And you see the deep attachment points for the ligaments. So this odontoid process is a signature odontoid process of herbivorous animals. I will show you more. So this is the beauty of the horse, but you have not realized the beauty of the craniovertebral junction ever. This is the beauty of a deer. You see the deer? I know it is very difficult for you to understand, but I will show you some beauties here. This is the C2, and you see the odontoid process. You see the odontoid process of the C2 almost like a circle. And atlantoaxial joint is quite large in a deer. The eyes are also placed laterally in a deer, allowing lot of lateral movement. The movement of the head of the deer is almost 170 degrees movement is possible at this joint. So if you see this, this is the C1 and this is the C2, and you see the odontoid process, And you see the articular surface of the odontoid process, atlantoaxial articulation coming anteriorly. You see the joint is not only lateral, but it is anterior, almost in a pattern of a semicircle. I hope you are getting to the point which I'm showing. This odontoid process is a signature odontoid process of herbivorous animals. The neck movement is quite big. It is not so much so in carnivorous animals. This is the posterior surface of the arch of atlas, on which huge muscle attachments are there. The transverse process is quite big. This almost includes the transverse process. This is the spinous process of the C2 and large transverse process of the C2 vertebra. The main issue which I'm trying to discuss today is the issue of the odontoid process, which is a signature odontoid. Before I go to odontoid, I want to show you, well, I'm not able. Okay. So this is the groove for the vertebral artery. I wanted to show you. I'm not able to go back. So now comes the king lion. King lion is the most handsome animal on the entire planet. You see the fantastic handsomeness. You see the face, quite a wide face at this point. And also the wideness of the ligaments. You see the wide transverse. This is the C1. This is the superior surface of C1. This is the groove for the vertebral artery. Large, flat transverse process to give attachment to the huge muscles that are attached here. More importantly, I am showing you the odontoid process. This is a signature odontoid process of a carnivorous animal. You see the large spinous process giving attachment to very strong muscles. This is the vertebral artery groove and a relatively small articular surface for C1. Odontoid process is like a peg or a dents, like in human beings. So what I say is, by development, human beings are carnivorous. So this is the fantastic, strong muscles and strong bones of a lion, king lion. And odontoid process is like a peg. And this is the groove for the vertebral artery. This is the groove for the vertebral artery. It goes in, then turns here, and then goes here. They're very fantastic. And if you see the beauty of the skull of a lion is this incisor muscle. If you see this muscle, which has the capacity to break the human skull into small little pieces, this incisor goes right, this is the orbital wall, it goes right in the orbit. And this is the zygomatic arch, and the temporalis muscle is having steel-like ligaments. The majority of muscle is white, steel-like ligaments, which help in this biting process by this incisor muscle. And you see the occipital notch, much huge and bigger, giving attachment to the suboccipital, strong suboccipital muscles. So that is the beauty of the odontoid process in carnivorous animals and in herbivorous animals. And I am showing you just two. and it is uniform. You see the bones of a dog are like human being. The bones of a goat are like a herbivorous animals. So size-wise, if you see the size, this is the human bones, this is the bone of a deer, this is the bone of a horse, and this is the bones of the lion. Now I want to show you the beautiful bird, beautiful. And if you realize the bones of this neck of the bird has the power to move circumferentially, 180 degrees. I want to warn the viewers that about 6:20 my internet breaks for about 7 minutes, so please bear with me at that time. So this king or queen bird has a power to move his or her neck almost circumferentially. How on earth can the neck move circumferentially? So there are some special characters in the craniovertebral junction which allow it to move circumferentially. So this is the ring of C1. And if you see the ring of the C1 ring has one body. And this body has a direct attachment to one condyle. So there is one body and one condyle. There are no two lateral masses or two articular surfaces. There is one condyle and one body. And you see the odontoid process here of C2 in a form of a latch. And on this one body, there is the possibility of circumferential movement in this beautiful animal. Now I come to odontoid bone. So a lot of articles, a huge number of articles have been there written about odontoid process. And one beautiful article I wrote on odontoid process, and this is my odontoid process fracture article. So you may not know and you may not have seen, many of you have certainly not seen this kind of a rickshaw. This poor man is driving this rickshaw sometimes with very heavy load. And this rickshaw he can run very furiously with this rickshaw. So in my beautiful article here, this article I had written, and if you can read this, such rickshaws are now sometimes seen in Kolkata, in one big Indian city. Now this man sometimes holds kilograms and very heavy loads. So what I had said in my article, that this rickshaw man, this rickshaw puller, is like odontoid process. He's not like a huge elephant or a huge strong man. He's not a power of this rickshaw. He's only the brain of this rickshaw. The design of this rickshaw, the wheels of this rickshaw, and this handle of this rickshaw makes the rickshaw carry very heavy weight. It is this brain, this rickshaw puller, nobody has the strength in the world to hold 500 kilograms and run. Nobody is that kind of a strong man. No Olympic strongman has ever been able to lift more than 300 kilograms of weight in even Olympics. No Olympian has ever been able to lift more than 250 kilograms in hand. So this poor man is not an Olympian or any kind of a abnormal kind of an animal. He's a very normal human being. And this design of the rickshaw makes him run. And he just have to hold and direct the rickshaw. So that is my philosophy, that this rickshaw is just the brain of the entire movement. The brawn or the muscles are provided by the design of the rickshaw. And this rickshaw puller is like the human disc. Disc has no muscles attached to the disc, but it is able to conduct the entire activity without moving any muscle.
Okay, we may have come to that break that Dr. Goel was referring to, so just hang in there and be patient. He usually comes back. Grab your tea or coffee. I'm going to eat some donuts. Feel free to take a snack.
John?
Very good. You're back. Carry
Okay.
on. Carry on.
Do you think some people are still there?
Oh, yeah. There's a lot of people here.
Okay.
We don't want to leave.
Okay. So now I'll come back. I hope there will be no further interruptions. So like this opera conductor, you see this opera conductor is not having any instrument in his hand, but he conducts the entire opera. And without this opera conductor, there will be no opera. So he's the brain of the opera. Maybe he's not actively involved in instrument handling and instrument, but he's the brain. Similarly, this fellow is the brain of the movement. And without this guy, the rickshaw will not be able to take direction or turn this side or that side and go from one destination to other destination. He's the brain. And I relate him like odontoid process. And I relate this gentleman like odontoid, beautiful odontoid process. And this odontoid process is like a disc. Disc is odontoid process in a similar location without any muscle attachment, without any direct activity, but it regulates the entire activity from birth till death. So this is divine. This odontoid process is the brain, is divine. Like the disc, which is divine. All the activity is being conducted from the muscles and are actively pursued by in the region of the facets. But it is originated and coordinated and conducted by the disc in the spine and odontoid process in the head. All the muscles are behind. They are acting with their focus on the spinous process, on the transverse process, and ultimately the fulcrum of the pulley is the facets. These are the facets, these are the muscles. This is the pulley. In this scheme of things, there is no odontoid process, there is no disc. This activity is going on, being conducted by the musicians, being regulated by the odontoid process and the disc. Disc is divine. So there are various muscles and ligaments circumvent around. You see, there is a small articulation here, which this on the back side of the odontoid process, and in the front of the odontoid process, there is an articulation. But basically, there is not a single direct activity being conducted by this. These threads are like these kind of instruments which the opera conductor is holding. So there are various muscles attached behind, lateral, and this kind of. Basically, the activity is conducted at the region of the facial articulation. So if you have to stop any activity, if you have to stop the activity, if there is some inactivity or some malactivity is going on, nothing, this divine structure has nothing to do with that. All the ill activities and malactivities are being conducted at the facetal articulation by the muscles. So my concept is very clear. My concept is these muscles, all the muscles are focused at the facets. And if you do not take care of the muscles, misuse, disuse, abuse, or injury of the muscles will focus on the facets, making facetal instability an issue. And this divine structure has nothing to do with this issue of instability. All the muscles are behind. So when there is odontoid fracture, now you will ask me what to do when there is odontoid fracture. And this is my article which I had recently written on odontoid fracture. What to do when odontoid is fractured. So there is a very common treatment of introducing a screw from front into the odontoid process. It is like treating God. My concept is, if a god is sitting in a temple, and if the god itself is damaged completely, you cannot repair the god. You can maybe make a new temple for it. So there are various types of classification. If you want to go in detail into what are these classifications of mine, you must go through this article. I will again give you that reference from World Neurosurgery, recently written article on my experience with 124 cases. So when there is a fracture of odontoid process, if you have to stabilize, the main issue is, when do you have to treat this? You have to treat when you find that the atlantoaxial joint is unstable. And when you find that the atlantoaxial joint is unstable, you have to stabilize the atlantoaxial joint in the best possible fashion. And that best possible fashion is from behind lateral mass plate and screw fixation, or rod and screw fixation. That is the best. And realign the craniovertebral junction if it is possible. When there is a fracture of the odontoid process, and whenever you see that there is a possibility of instability, there are various parameters to assess the possibility of instability. You fuse the atlantoaxial joint, and this is delayed after several years of fusion. Essentially, when you think the joint is unstable, you need to treat this. And when you think it is not unstable, or it can be stabilized by halo fixation for a period of time, that is a possibility. But whenever you have to treat in a final manner, not in a semi-final kind of manner. And in a delayed kind of fashion, there can be self-restoration or self-fusion which can happen. But if there is a possibility of instability, you treat it by stabilization. So that is my concept in situations of atlantoaxial instability following odontoid fractures. You stabilize the atlantoaxial joint, and you don't do any half-hearted kind of screw fixation here or screw fixation there. If you think it can stabilize by one screw, maybe it is your option. But my strategy is, whenever instability is considered to be a possibility, you stabilized by the best possible treatment fashion, and that is lateral mass plate and screw fixation. So there are several cases of mine over several years. Lateral mass fixation, I used to do anterior treatment once upon a time, but now for a long period of time, only lateral mass fixation is the treatment for odontoid fractures. And that treatment comes into play when you think that atlantoaxial instability is the problem. Now, other very beautiful issue which I want to discuss with you is the issue of os odontoideum. And this also I have recently published, and you must see my article on this subject, where I mention in this article, and you must read between the lines, that odontoid process is a divine structure. Os odontoideum is not an embryological issue or a problem I mention in this article. I say that os odontoideum is a natural protective maneuvering by God. Now, what is this natural maneuvering? I will like to show you. So this os odontoideum you have seen on several occasions. And when you see this os odontoideum, you think that there is a problem here, and there is an unstable spine, and you need odontoid process is pathological, and this certainly needs stabilization. So this is the concept. I must say that this concept, that this os odontoidium is an indicator of atlantoaxial instability and it needs atlantoaxial stabilization. It looks very simple, but if you read the literature, this concept is not at all clear in the literature. There are many people in the world still preferring to do transoral decompression, and there are several people in the world today who are preferring to do occipito-cervical fixation for this entity, which is completely, in my estimation, a negative kind of operation. Decompression from the front and occipito-cervical are completely negative operation. This is not a pathological phenomena. This is a divine intervention, indicator of atlantoaxial instability, and indication of the need for atlantoaxial stabilization. I will like to show you some more cases. So when you see this os odontoidium, you immediately think that this is a pathological problem, an embryological disturbance, and this gives rise to atlantoaxial instability. So this is primary and instability is secondary, and stabilization is the treatment, atlantoaxial. Of course, the literature still says occipito-cervical stabilization and transoral decompression. The issue is clear in the literature that this is pathological and gives rise to atlantoaxial instability. So this is one of my more beautiful articles, which of course I cannot repeat it. If you want to see this and see these divine interventions, you have to read this beautiful article. When there is atlantoaxial instability, there are lots of divine things happening. Divine majesty, the glory of God is to conceal a thing, but the glory of the king is to find it out. So God is concealing the facts and glory of us neurosurgeons. If we think we are kings, we cannot ever think we are gods, but we can certainly think we are kings. But we should always remember that we are quite innocent and we are children in front of this divine majesty. And we should at least make an attempt to think about the games the gods play when there is atlantoaxial instability and how the natural reparative mechanisms come into play. So as I had shown you this article, atlantoaxial dislocation there are various musculoskeletal abnormalities which are reversed on stabilization. So there, this torticollis, short neck, I had introduced to you the other day, short head, short spine, torticollis. This can be reversed immediately after you do atlantoaxial fusion, fixation. So these are not abnormality. These torticollis and short necks and short head and short spine are not abnormality. They are natural reparative mechanisms. They are protective mechanisms. Similarly, I had said that cervical fusion is a protective mechanism of the body. Bifid is a protective mechanism of the body. These are not abnormal mechanism or these are not pathological phenomena. They come into play when there is atlantoaxial instability. So these bone fusions and bifid are not embryological problems. They are games that gods play. They are divine games. Basilar invagination, syringomyelia, Chiari formation are not pathological or embryological dysgenesis, but they are divine plays when there is a phenomena called atlantoaxial instability, which is a man-made phenomenon. If you are not taking care of your muscles of the back, if you are injuring your muscles, then there comes a phenomena of atlantoaxial instability. Remember, just imagine a situation, there is sudden car accident and you have broken your spine, there is atlantoaxial instability. You touch your occipital muscles, they will be under such huge spasm that this spasm is like a rock. And this rock-like spasm is a protective mechanism of the body. Similarly, in chronic protective situation, the neck muscles are under spasm and basilar invagination, musculoskeletal abnormalities, syringomyelia, and Chiari formation are secondary divine intervention. So I had said, and I have shown you the other day, that syringomyelia is not harmful. Syringomyelia is protective mechanism. Chiari formation is a protective mechanism. So I am repeating this again and again in my several lectures for a small group of people who are sitting in front of me and wanting to hear me. But if you are hearing and if you are understanding, I will suggest you please go and read some of these articles which are saying that atlantoaxial instability is the primary problem. Fusions, assimilation of atlas, C2-3 fusion are protective mechanisms. So now come to our question. Os odontoideum is very frequently associated with bifid arch of atlas. It is very frequently associated with C2-3 fusion. And I am introducing to this concept that this odontoid process breaks itself. Suppose this odontoid process had not broken and it was up till here, it would have clearly, you see, this odontoid tip has naturally broken. This odontoid process, if you have seen the tail of a lizard, and if a cat comes and catches hold of the lizard, it gives away its tail. Similarly, God gives away this odontoid process and it protects the cord. And many of these os odontoid patients, there will be severe cord compression and the symptoms are quite marginal. Imagine if this odontoid process was intact, it could have completely transected the cord. So bifid, presence of bifid, presence of C2-3 fusion, presence of os odontoideum are divine interventions. Now you see this. This is os odontoideum. Suppose this os was stuck here, the cord would have completely transected. You see the bifid, there is no, imagine if the posterior arch of the atlas was intact and the os odontoideum was intact, there would have been no space for the cord. And this patient, I must tell you, ladies and gentlemen, sitting here, has come to me with very marginal symptoms because of the divine intervention of bifiding of arch and introduction of os odontoideum or breaking of the odontoideum os and bringing it in front in a very non-specific kind of location. But this formation is an indicator of an unstable atlantoaxial joint meriting the need for fixation. And this, once you fix, the fusion of this area will automatically come and the bifid will not remain bifid. This, I had told you that this retroodontoid cyst formation is also a natural protective mechanism. You do, and a cushioning of the cord, you do fix from behind. Chiari malformation is cushioning from behind. This is cushioning from front. And you do fixation, this cushioning is no longer necessary. Degeneration of the craniovertebral junction is a very common clinical entity, never discussed in the literature. My article in 2010 was amongst the first articles on this subject, where we had discussed about degeneration of the spine and ossification in the para-odontoid region, presence of osteophytes, presence of buckling of ligaments, reduction of the disc space are divine intervention indicators of atlantoaxial instability, meriting the need for stabilization. Ossification in the apical ligament is not os odontoideum. It is a natural protective maneuvering. See the ossification here, see the ossification here. These are all indicators of a divine phenomena, divine protective mechanisms, which are telling us that there is some problem in the joint. You please take care of the problem in the joint and fix the problem. Don't disturb me. This is not to be disturbed, my dear friends. This is an indicator to human eyes that atlantoaxial joint is unstable. This kind of abnormal ossification here, you must see when you are seeing the image. These are indicating that the atlantoaxial joint is unstable, and this instability is not by this instability is by you and by me, because we have not taken care of our muscles. There can be multi-level spinal instability and atlantoaxial instability. You treat by stabilization, not by decompression. Decompression is certainly a negative treatment. You see this artificial bone formation. Osteophytes are indicators of an unstable atlantoaxial joint, an unstable spine. Decompression is not the treatment. Stabilization is the treatment. When you see this compression, don't suddenly start jumping on the bones. Don't suddenly start jumping and killing the odontoid process. You stabilize the joint, and then after 2-3 months, when the fusion has occurred, ask this gentleman to do extensive exercises, and he will be all right. Presence of posterior longitudinal ligament thickening, presence of osteophytes, presence of bone abnormal. Don't call this abnormal bone. This is divine intervention. Don't call this bone, posterior longitudinal ligament ossification, abnormal. These are divine intervention, which tells you that there is an unstable craniovertebral junction. This posterior longitudinal ligament is not abnormal. Don't start breaking it and removing it. Don't start removing the odontoid process. These are indicators of atlantoaxial instability and indicators of the need for stabilization. This is not a pseudotumor. This is osteophyte formation, which is an indicator of need for atlantoaxial stabilization. So I'm showing you some of these beautiful articles. This is not abnormal. This is cushion from front, Chiari is cushion from behind, indicators that stabilization is the treatment. Pannus it is not a pathological phenomena. It is buckling of the posterior longitudinal ligament. So whatever is inside the odontoid, whatever is outside the odontoid is the game of God, is the game of nature. It indicates to you an unstable phenomena. It indicates to you the potential vertical spinal instability, which is the cause of problem not only of atlantoaxial joint, but the entire spinal spondylotic disease is an issue of vertical spinal stabilization is the issue. So my recommendations for you will be exercise and keep your muscles strong. Particularly this COVID time is a good time to exercise your muscles. Don't injure your muscles by accident. Do not blame your disc or your odontoid process ever. There is no terror of error in nature, my dear friends. Thank you very much.
Okay, very good. Thank you very much, Dr. Goel. And
You
we have
think?
a lot of panelists here, and I'm sure.
Okay. Now,
I'm
can you get me out of this? And can
Yeah,
you get
sure. Yeah, sure. Let me get you up right now. Okay, the floor is open for comments or questions with Dr. Goel.
Now, before the comments are open, I will again like to ask the panelists. Say yes if you think there is some divinity there, and say no, that this is all useless. This is game of, please say yes or no. I want to see that on your chat box. You can go to your chat box and say yes or no. I want to see how many people are saying yes and how many people are saying no. If there is any doubt, please say no.
Okay, overwhelming. Just like I thought, people just aren't leaving during these delays. They're just not leaving, Dr. Goel. So let's continue. Let's just continue.
So you can see that, John,
Yeah,
divine,
yeah.
God
Yeah,
is
yeah.
God is present,
Well, people are
and
staying
God is
here.
there.
People are staying.
You see, that is why if we are, this, we can, God will help us get over this COVID, this virus. You just pray to God and don't start removing unnecessary, we have to. So so John, you see, I am thankful to all the panelists and to
Okay, it's
introduce
overwhelming,
this
overwhelming.
subject.
Yeah. So you can continue with no delay.
So that is my, and if there are some questions now, John, I will be happy to answer.
Good. Okay. Okay, step forward, people with comments or questions. Don't be afraid. This is a platform for interactivity.
Hi, Professor Goel. Thank you very much. That was
Yeah.
a beautiful, beautiful. It's these are not very common talks. The stuff you're showing it takes you out of your comfort zone, and unless you're like I think what you mentioned before, you have to be mentally supple to listen and have the humility to at least take that first step forward. And I think that's what all the panelists are highlighting here. My question is, when you have people that have come back to you from, if someone has done a Chiari decompression, a C1 laminectomy, do you still propose the C1, C2, or do you, in that case, make an exception to go to the occiput, or will that provide enough stability if it's already been done before?
Yes, Abhilash, let me answer that question. You see, when there is a decompression done, it is, there is no question, Abhilash, there is no question absolutely that it is a wrong operation. Now I have got an experience of hundreds of patients. The problem is, what is the problem? The problem is that to do C1, C2 fixation in presence of Chiari formation and presence of syringomyelia is quite a difficult operation. It's not an easy operation because the venous congestion in that area is quite huge in that situation. Now, if there is a decompression done, now I have got a very big series of patients who have already undergone decompression. And I recommend C1, C2 fixation with a new introduction of new life. Now I say, you will be surprised when the patient comes to my clinic after the operation. You know what is my question? You answer yes or no. Have you got a new life? You say yes, I have got a new life. Or you say I have not got a new life. My question is new life. So that is and C1, C2 occipital bone is a historical operation. I never include occipital bone ever. And Abhilash, in entire US, in the whole country of US, there is not a single person in US who is doing C1, C2 fixation. Very, very few people. And I'm sorry to say this, but this is a fact and you know it. And this, the problem is, the question is, they are not ready to listen to, agree that there is some divinity in nature's powers. There is so much technicality and technology that they are not ready to listen. And when my article was published in Journal of Neurosurgery, there were huge comments on, he said, what is this and this and this, we are doing decom. See, I am not trying to blame anybody. Abhilash, you must understand, I am not here to criticize anybody. I am not here to blame anybody. I am just giving you my perspective, and I am giving you my huge experience on this subject, showing you several if I'm not sure if you attended my lecture that on Chiari formation, which I gave for 2.5 hours with several cases and several cases with syringomalia. I don't know how to prove this point. If you have some advice for me as to how I can prove this point, you please let me know, Abhilash, because you are in that system.
Yeah,
That
I mean,
is the issue.
I think what you're bringing up as an important point is that you're ultimately a victim of your training. That is the bottom line. Where you train makes a huge difference. So these venues really open, you have to open your eyes and be willing to listen to other countries, irrespective of, it's not a...
Now, another issue, Abhilash, another issue too for you and for many people in US. You have seen this os odontoideum. You have seen this small presentation.
Yes.
100% of people in US, 100% are doing occipito-cervical for this. And 80% of people are doing transoral decompression for this, which in my estimate is an absolute uneducated form of treatment. Now I'm using very harsh words for this, but this is a very close kind of community, which is, I hope this lecture goes and what my feeling goes to others. But 100% of people in US still are doing occipito-cervical fixation for os odontoideum, 100%, not 98%. So this is the issue. Now I have given my series of 198 cases of os odontoideum I have recently published in World Neurosurgery. I hope there is some change in the world. I hope, but I'm not sure, because the concepts are that nothing can come from a country, from a slum hospital from India. Nothing can come new. That is the concept. I hope you can change this, Abhilash, for this understanding and this egoistic kind of feeling.
Yeah, your passion resonates very, very well, and I think it's awesome. You're extremely inspiring, and thank you so much for taking your time out of your busy schedule to teach all of us.
Thank you, Abhilash. Thank you. Is there any other question?
Yes, Professor Goel, I'm truly an admirer of your passion, your your decision and your move to stay out of the line, no matter whose ox is God, because you've made salient points here, and it takes somebody with a soft mind to open up and then absorb a few things and then not think straight, think wide. People have been trained to believe that one way is the best, and they try to impose that on other people. And most of the times that is what happens. And your statement about what happens in developing countries versus developed countries is evident. That times we present new ideas and even the abstract is not accepted because they think someone coming from this and that region, what do they have to offer? It does not make sense in the ideology of global neurosurgery, where a certain group of people are still isolated. But sincerely, I admire you because my trainer, who is retired now, used to think just the same way you folks, permit me to use the title, old schools, used to think, and it makes it broad. You are someone that is well-rounded, not subspecialty. You are able to take on anything and that's the kind of training we were given
Thank you very
before
much.
branching
Thank
out.
you. Thank you so much.
I
So
really
nice of
appreciate
you. Thank you.
Okay,
John?
Go ahead, more comments, questions?
Maybe there is only yes, there is no other comment.
Oh, just wait a second. I'm sure people will get less shy and less shy with this tech. It's just so new to everybody. I think most people taking the leap. Okay. I usually threaten I'm going to sing unless someone asks a question. Adnan, do you have any comments or questions for Dr. Goel? You there, Adnan? There you go. Go ahead, Adnan. Oh, perhaps his audio is not working correctly. Let me see here. What else we have here that I can pick on? Let's see. Okay.
Okay, John. Is there
Okay.
anything?
Yeah, anybody else? Come on, look, you guys. Dr. Goel, there's a chance to interact with them. Come on, take your chance. Okay, I guess people are being a little more hesitant today than normal. So, okay, Doc, I guess we'll see you tomorrow. The overwhelming opinion is that they'll take the tech slowdowns just to be in the same room with you. So,
Thank you. Thank you so much. Thank you, John. Bye-bye.
okay, see you tomorrow.
Bye-bye.
Bye-bye.
Yep. Bye-bye.